Dear all, I will be discussing today with a small topic that is anion gap. Now, this is important for all the students across all phases of the MBBS course. Is also important for clinicians who are regularly looking up the patients in emergency ward, and therefore it is an integrated topic on anion gap. Let us understand now. Normally, plasma electrolytes are cations and anions, and there is a balance so that there is electrical neutrality. Now, some cations and anions are measured, others are usually not measured. Now, the measured cations constitute 95% are plasma sodium and plasma potassium. And the measured anions, which constitute about 80%, are plasma bicarbonate and plasma chloride. Now, unmeasured anions, which constitute about 20%, include proteins, phosphate, sulfate, urate, and organic acids. Among the proteins, albumin constitutes the main component of unmeasured anion. Therefore, changes in the levels of albumin would alter the anion gap, and we will see an example of such alteration in the coming slides. Now, apart from the unmeasured anions in clinical situations in diseases, addition of the acid in the form of the toxin can also alter the extent of unmeasured anions, and this is important in poisoning. Now, unmeasured cations are usually calcium, magnesium, and gamma globulins, and they are usually not considered for calculation because they rarely alter in such a way that anion gap is changed significantly. Now, let us understand the anion gap. Now, anion gap is the sum total of sodium and potassium, and there is a sum total of bicarbonate chloride which is subtracted from the sum total of sodium and potassium. That is equivalent to unmeasured anions minus unmeasured cations. Since unmeasured cations contribute very little, so they are often ignored in the calculation. Therefore, anion gap means unmeasured anions only. Now, therefore, we can also represent this equation, that is sodium plus potassium is equal to chloride plus bicarbonate plus the unmeasured anions, which is represented as A minus. Now, since in many equations in many books you would find that potassium is not included, only sodium is included, and this is because potassium offers little practical advantage over sodium alone. So there are two ways of presentation of anion gap. One includes potassium, the other doesn't include. Including potassium as a routine in many books is there. Therefore, this formula would be anion gap is equal to 15 milliequivalents per liter, which can be considered as normal value. Now let us see what is the normal range. Normal range of anion gap is 12 to 16, and if you do not include potassium, the value will correspondingly be reduced. Now, an increase of over 15 milliequivalent per liter is always considered high, and the level which is less than 9 milliequivalents per liter is considered low. Here I will be discussing most of time the higher anion gap because it has greater clinical significance. Now, a related term is osmolar gap, which also is important in assessment and evaluation of the metabolic disturbance in the form of acid-base imbalance, and this will be a separate presentation in coming time. Now, as stated earlier, the anion gap should be corrected for the level of albumin, because albumin is considered to be the main unmeasured anion and its levels would vary. It is said that hypoalbuminemia will mask elevation of anion gap, and 1 gram reduction in the plasma albumin will mask or reduce anion gap by 2.3 to 2.5 millicoulomb per liter. Obviously, there is a need of adjustment of anion gap vis-a-vis level of albumin, and this is called as adjusted anion gap or albumin corrected anion gap. And the formula is anion gap, whatever way we calculate, sodium plus potassium or sodium alone, plus 2.5 times the difference of normal albumin versus estimated albumin. I'll repeat it. Anion gap plus 2.5 times the difference of normal albumin and estimated albumin levels. Example is, if sodium is 135, bicarbonate is 23, chloride is 100 milliequivalents per liter, albumin is 2.5 grams only. So it is a case of hypoalbuminemia. Then the corrected anion gap will be 135 minus 123 plus 2.5 difference of albumin 4.5 normal minus 2.5, so it will be difference of albumin 2. 2 multiplied by 2.5 will be 5, so a difference 10 would be 12 plus 5 is equal to 17 milliequivalents per liter instead of only 12 milliequivalents per liter if it is not adjusted with albumin level. So here we can realize that albumin adjustment is important. Now, what are the clinical uses of calculation of anion gap? Anion gap is calculated to classify metabolic acidosis as high anion gap metabolic acidosis (HAGMA) when levels are more than 12 milliequivalent per liter without potassium, and the anion gap is high because there is either endogenous or exogenous acid. For example, in diabetic ketoacidosis, lactic acid and beta hydroxybutyrate contribute to the high level of anion gap. However, the metabolic acidosis can also be due to normal anion gap metabolic acidosis or NAGMA, and here bicarbonate loss is the main component, and loss of bicarbonate is compensated by retention of the chloride. So overall, it is hyperchloremic metabolic acidosis. And therefore, we can classify the metabolic acidosis depending on the anion gap. Now, for example, in diabetic coma, coma may be because of diabetic ketoacidosis or it may be hyperosmolar non-ketotic coma. Anion gap will help us differentiation because diabetic ketoacidosis will have high anion gap, whereas non-ketotic coma, that is hyperosmolar coma, usually has a normal anion gap or only there is a slight increase in anion gap. So this is the main utility of anion gap calculation. The second one is that it can diagnose a mixed acid-base disorder. For example, it will help us finding out existence of metabolic alkalosis along with metabolic acidosis. A simple example will be given in the next slide. Now let us understand what are the causes of high anion gap and normal anion gap metabolic acidosis. Now causes of high anion metabolic acidosis is because there is increase in unmeasured anions which can be endogenous or exogenous. Now endogenous acid overload can occur in diabetes, ketoacidosis, starvation ketosis, lactic acidosis, in shock, in liver failure, and the use of fenformin. Fenformin is no longer used nowadays. Now, uncommon cause which should be remembered is D-lactic acidosis. Now, this is uh, an uncommon condition which occurs in bypass surgery, particularly ileal bypass. When ileum is bypassed and direct the metabolites reach to the colon. Now, another cause of endogenous acidemia causing high anion metabolic acidosis, renal failure, where there is accumulation of organic acids. Among the exogenous causes of hagma are poisoning, toxins, methanol, ethylene glycol, propylene glycol, and uncommonly 5-oxoprolinuria. Aspirin poisoning is again an important cause. For every for every toxin, there is formation of one acid. For example, aspirin will add salicylic acid and derivatives. Methanol will add formic acid derivatives. Ethylene glycol will add oxalate and glycolate. So in this way, there is exogenous acid that increases unmeasured anions. Now, among the normal anion gap metabolic acidosis, which is usually hyperchloremic acidosis, classically seen in acetazolamide overuse and ifosfamide, which also causes proximal tubular defect like Fanconi syndrome. But the most common cause is diarrhea, where there is a fluid loss and bicarbonate loss. Among the renal causes, there could be renal tubular acidosis, proximal variety type 2, distal variety type 1, and type 4, which is hypoaldosteronism variety. All these can cause loss of bicarbonate, but anion gap is normal because it is compensated by chloride retention. So this is how we can find out the causes also. Now, in the differentiation of mixed acid-base imbalances, anion gap metabolic acidosis shows that anion gap increases proportionately to the fall in bicarbonate level in a ratio of 1 to 1. That is, if there is 1 milliequivalent fall in bicarbonate, there will be 1 milliequivalent rise in anion gap. This relationship may occur under normal conditions. However, if fall in the bicarbonate is less than anion gap rise, I'll repeat, if fall in bicarbonate is less than anion gap rise, it suggests coexisting metabolic acidosis. Conversely, a proportionately larger drop in bicarbonate than in the anion gap drop suggests mixed disorder of anion gap acidosis with non-anion gap acidosis. That means there is acid retention plus also bicarbonate loss. So this is how we can find out. A practical approach clinically for clinicians is an anion gap of over 20 is mostly due to primary metabolic acidosis, irrespective of the value of bicarbonate. But if the calculated bicarbonate value is over 30 milliequivalents per liter, that means there is associated metabolic alkalosis. How do we calculate the bicarbonate level? Excess anion gap plus measured bicarbonate level will be called as calculated bicarbonate level. And the excess anion gap is measured anion gap minus normal anion gap, that is 12 milliequivalents per liter. So this is how we can calculate bicarbonate level calculated, and that will estimate it. That will give an idea about the mixed disorder. Now, two variant another ways of the method of identifying mixed disorder. One is delta ratio, which is less commonly used. That is anion gap minus 12, which is normal anion gap, which is divided by 24, that is the normal bicarbonate level minus estimated bicarbonate level. And this ratio will give an idea of the whether the disorder is nagma, hagma, or a mixed disorder. For example, if ratio is over 2, this is due to mixed hagma and metabolic acidosis. Whereas if ratio is less than 4, it is due to pure nagma. Whereas if ratio is between 0.8 and 0.2, it is due to pure hagma. But between zero point 0.4 and zero point 0.8 ratio, there is a mixed nagma and hagma. So this also indicates the mixed acid-base disorder. Another way is finding out delta gap. It is again less often used but can be useful sometimes. Delta gap is a change in the anion gap minus change in the bicarbonate. In a simplified equation, it will be sodium minus chloride minus 36, which has been calculated as the figure. Now, the interpretation is normal value of delta gap is 0 because anion gap and bicarbonate change together occur in opposite direction as told earlier. However, if delta gap is positive, that means bicarbonate is changing significantly less than anion gap, and that means coexistence of metabolic alkalosis. However, in an example where delta gap is negative, and that means there is a coexistence of metabolic acidosis, another acidotic disorder. A value of more than 6 means presence of mixed high anion gap acidosis with metabolic alkalosis. So this way, by using delta gap in place of delta ratio, we can find out the variation and concurrence of the mixed acid base disorder. Now, there is a value of urinary electrolyte estimations and urinary anion gap estimation. Now, normal urinary cations, we all know, they are sodium, potassium, ammonium, calcium, and magnesium. And normal urinary anions are chloride, bicarbonate, sulfate, phosphate, and some organic anions. What is more important, that clinically relevant only sodium, potassium, chloride are there, and they are commonly measured in urine. So other charged ions can be considered as unmeasured anions and unmeasured cations. The main urinary unmeasured cation is ammonium, which represents 90% of acid excretion by the kidney normally. This is very important. Now, a rise in urinary ammonium cation will cause fall in urinary anion gap because they go in opposite direction. Now, therefore, urinary anion gap calculation can be useful in differentiation of hyperchloremic metabolic acidosis when there is normal anion gap metabolic acidosis. And here we can measure the urinary anion gap and urinary pH. Now, urinary anion gap is sodium plus potassium minus chloride, and that represents the difference of unmeasured anions and unmeasured cations. Now, simply we can say that urinary anion gap is equal to unmeasured anions minus unmeasured cations, and normal value is either 0 to less than 10 milligrammes per liter. In metabolic acidosis only, urinary anion gap is strongly negative and ammonium ion is the major unmeasured urinary cation. A negative urinary anion gap suggests gastrointestinal loss of bicarbonate with increase in ammonium excretion. A positive anion gap suggests altered urinary acidification, as in distal tubular acidosis. This will be clearer in the next slide. So, urinary anion gap will be used to differentiate non-anion gap acidosis due to renal and extrarenal causes. In extrarenal causes of non-anion gap acidosis, the value is largely negative because kidney generates ammonium ion and excretes. Whereas in renal causes of non-anion gap acidosis, the value is positive more than plus because kidney cannot generate ammonium, so it cannot excrete acid. So this is how, when there is a dilemma of differentiation of non-anion gap metabolic acidosis with hyperchloremic response due to renal causes or due to extrarenal causes, then urinary anion gap will be helpful. So in summary, anion gap is a useful biochemical parameter in differential diagnosis of metabolic acidosis due to acid overload, which may be endogenous or exogenous, and loss of the bicarbonate, which may be due to renal or extrarenal causes. Diabetic acidosis or ketoacidosis is the most common cause of hagma, that is, and diarrhea should be considered as the commonest cause for non-anion gap metabolic acidosis. Now, any deviation from the expected change in the anion gap in metabolic acidosis would indicate a mixed acid-base disorder, which has been discussed earlier. Urinary anion gap helps differentiating renal from extrarenal causes of hyperchloremic non-anion gap metabolic acidosis. So this finishes with this presentation tutorial. Thank you very much for the joining, and I will present the osmolar gap, which is related to acid-base disturbances also, in the next presentation. Thank you.